Well, thanks very much for inviting me. Thanks, Lisa. Great talk. I learned something too. Now we're going to switch gears and talk about pediatric lung transplant. Over the next 45 minutes or so, I am going to review the indications and contraindications to lung transplant, spend a good chunk of time talking about outcomes and complications after lung transplant, and then finish up talking a little bit about challenges and opportunities. I'll just give you a heads up. I've got a couple of polls in the middle of the talk that I'm going to ask for your input on, and then we're going to try a little table exercise at the end to get you broken up into groups, so just be prepared for that. So let's start by just asking the general question, why would you do a lung transplant? First of all, you need to have untreatable end-stage pulmonary parenchymal or vascular disease. There needs to be a low probability of recurrence of the disease process, no other significant medical diseases that would get in the way of a good outcome. There has to be a significant limitation of daily activity to trade the complications of the disease to the complications of lung transplant that you'll see as we get into this. The patient has to be able to rehabilitate, and there has to be a satisfactory psychosocial support system to get the patient through what's a very complex journey. There are absolute contraindications to lung transplant. Many centers have the same. First of all, second major organ failure is a contraindication to lung transplant alone, although we will consider heart lung transplant and liver lung transplant in the appropriate circumstances. In patients with cystic fibrosis who are colonized with Burkholderia cenocepacia, most lung transplant centers consider that an absolute contraindication. HIV infection is an absolute contraindication in most pediatric centers, although there are some adult programs that are now taking care of patients, doing lung transplants in patients with well-treated HIV. Hepatitis B or hepatitis C infections are considered absolute contraindications, although now with the treatments that are available for hepatitis C, that is beginning to be an option for some patients. Active malignancy within the past 2 years is generally considered an absolute contraindication because of the risk of recurrence. And progressive neuromuscular disorders typically are considered an absolute contraindication because you can't fix the pump with lung transplant. There are also relative contraindications. Invasive ventilation is a risk factor for poor outcome in adults and older children. It's less clear whether invasive ventilation is a risk factor for poor outcome in infants. Colonization with fungal organisms and atypical mycobacteria are also a risk factor for poor outcome. For the most part, in the fungal colonization, we're trying to treat with post-transplant prophylaxis, particularly for Aspergillus. For atypical mycobacteria, particularly Mycobacterium abscessus, most lung transplant programs are trying to eradicate the organism from the smear before taking to the patient to transplant. If for some reason single lung transplant is being considered, the retention of an organ that's damaged, that's also infected with a difficult organism, can be a problem. So generally, these kinds of organisms can be a pretty strong contraindication to a single lung transplant. Psychosocial issues play a role in pediatric lung transplant. We're reluctant to transplant patients who have major psychoaffective disorders, and patients with refractory non-adherence are also not good candidates for lung transplant. In general, we're working with the pediatric referral center to address any non-adherence issues before we get the patient to transplant, often creating a contract for adherence that we hope the patient and family will follow. So you wonder what diagnoses are coming to transplant in pediatrics. This is a slide from the International Society for Heart and Lung Transplant, which has a registry of thoracic transplants that they report on every few years, or every year to every few years. Let's focus on the middle column here, which is North America. You can see that about half of the patients who come to transplant in pediatrics have cystic fibrosis. And there's a large variety of other things, the different interstitial lung diseases, bronchiolitis obliterans, pulmonary hypertension in a variety of forms, and a large group of other things come to transplant in pediatrics. This slide shows the number of pediatric lung transplants over time Again, data from ISHLT, and the things to take away from this slide are twofold. First of all, the number of pediatric lung transplants reported to the registry is only about 100 to 120 per year. So this is not a very high volume proposition, and it's usually done in a relatively few number of transplant centers around the world. The second take-home message is that the vast majority are done in adolescents. The next largest group is in the 1 to 5 and 6 to 10-year-old populations. Infant transplants are only a handful every year. So let's talk for a minute about infant lung transplants and ask the question, what's different about those? What diseases come to transplant in infancy? And then what are the challenges? So in infancy, you can have parenchymal lung diseases. You heard a lot about many of them from Lisa just a few minutes ago. In terms of the child disorders, filament A, rarely bronchopulmonary dysplasia is an indication for lung transplant in infancy or young childhood. Pulmonary vascular diseases, including pulmonary hypertension related to congenital heart disease. Lisa mentioned ACD, MPV. Also, pulmonary vein stenosis is an indication for lung transplant in infancy. And then occasionally patients with congenital diaphragmatic hernia who have pulmonary hypoplasia and pulmonary hypertension associated with it can come to lung transplant. Lung transplant in infants and toddlers brings additional challenges. It's much more difficult to assess lung function in an infant. We have infant lung function testing, but it generally requires sedation and it's complicated. Bronchoscopy and transbronchial biopsy is more challenging. You can get biopsies in infants, but the pieces are smaller and the pathologists have a difficult time interpreting them. And then the question of whether or not transplanted lungs will grow and how well they will grow remains an open question. In our center, patients have to be at least 3.5 kilos to be listed for transplant. That's because the likelihood of getting organs smaller than that is pretty difficult because of what infants and young children typically die from. Generally, we're looking for patients whose estimated gestational age is greater than 26 to 28 weeks. For patients born less than that, the combination of developmental risks and other organ risks, we believe, makes the likelihood of a good outcome after lung transplant pretty poor. And so we're looking for patients who have survived to being discharged from the hospital in this situation. Again, no other organs can be involved, and in many cases, these patients are pretty unstable, so just getting them to the transplant center can be a challenge. The diagnoses that come to transplant in infancy is a little bit different than what you see in older patients. This is a slide from our own experience at St. Louis Children's Hospital, and what you can see from this slide is that about half of the patients come with different types of pulmonary vascular disease, and about half of the patients come with pulmonary parenchymal diseases. Notably missing, not surprisingly, is cystic fibrosis from the slide of infants and toddlers coming to transplant. So then the question becomes, when do you refer a patient for transplant? In general, there's no downside to early referral, at least getting in contact with your lung transplant center that your center works with to understand when that patient would benefit. For patients with cystic fibrosis and other forms of bronchiectasis, typically if the FEV1 is dropped down into the 40–50% range predicted, particularly for cystic fibrosis, that's a good time to start talking to the transplant center, although we're still going to wait until their lung function is down closer to 30% before we get serious about transplant. For pulmonary hypertension, we're looking at patients with progressive disease despite therapy. Typically, cardiac index of less than 2 liters per minute per meter squared, an elevated RA pressure and elevated PA pressures. Patients who have had hemoptysis or syncopal episodes are at higher risk. And we also consider patients with pulmonary hypertension for a pot shunt, which is basically it's a pop-off valve to the lower circulation to reduce the pulmonary artery pressure and improve cardiac output. And so in the subset of these patients, we're doing pot shunts to delay transplant. For infants with congenital respiratory failure, particularly surfactant protein B, ABCA3 and NKX 2.1, and severe pulmonary vascular disorders such as ACD or MPV and pulmonary vein stenosis, you really need to get the patient to the transplant center soon before they end up on ECMO or in severe respiratory failure. Other diseases, the timing of transplant is less clearly defined, and it's really on the basis of respiratory function, supplemental oxygen requirement, nutritional status, and overall comfort of you and your team and the transplant center in terms of taking care of the patient. So what do we do at the time of a lung transplant evaluation? Well, first of all, we're evaluating where the patient is in terms of their pulmonary function. We're looking to do imaging studies, both to establish the extent of lung disease, to evaluate the pulmonary function or the cardiac function. In patients who have asymmetric lung disease, we may do a VQ scan, and we're getting functional capability testing using a 6-minute walk test. We're doing laboratory testing to evaluate overall organ function, to look for evidence of viral infections that could complicate the transplant, particularly hepatitis, CMV, and EBV, which I'll mention a little bit farther down the road. We get sputum culture to understand what the organisms are that the patient is colonized with, and we measure antibodies to HLA, the tissue type, to understand what the risks are of getting an organ with a different tissue type. So if there's an antibody present to a different tissue type, getting an organ with that tissue type could create problems. And then finally, we're getting a psychosocial evaluation. We have our social worker, our child psychologist, our child life specialist, and our financial coordinators evaluate the patient so that we fully understand the barriers on the psychosocial side to a successful outcome and understand what it's going to take to make that happen. So this is the first poll. Let me see if we can make this work. You have a patient with, let's try that one more time. Full-term patient who's presents with respiratory distress syndrome, 3.9 kilos, born at 40 weeks, respiratory distress at birth, intubated in the delivery rooms, chest x-ray with ground glass infiltrates, didn't respond to surfactant, and now is 2 weeks old and has slowly increasing respiratory support. And you've done an open lung biopsy, and that shows alveolar proteinosis. So the question is, for this full-term infant with respiratory distress syndrome, what is the least likely diagnosis? And let's see if I can launch this poll. And so here this poll is up, answer the questions, and we'll go from there.
So Stuart, you end the polling, you just click on polling. Looks like the responses have slowed.
Yeah.
And then everybody has to X out when they're done. It won't move off your screen. Each individual has to X out.
Okay, so here's the results. Looks like most people saw it was number 3, and next number was D, and surfactant protein C. So I'm going to close the poll results, and we'll go on to the next slide. And in this case, actually, the answer is surfactant protein C deficiency. The majority of these patients don't show up in infancy with respiratory failure. The classic case is SPB deficiency, but as you heard earlier, ABCA3 and NKX 2.1 can also show up with refractory respiratory failure in infancy. So this was sort of a difficult question. So let's talk about the next steps. You bring the patient to the transplant center, you've evaluated them, you've decided that they are a good candidate for transplant, and now they get the offer of organs and you take them to transplant. What do your surgeons do? Well, it turns out that the most common operation that the surgeons do is called a bilateral sequential lung transplant. And it's what we most commonly do. It's typically done through a clamshell incision, which is just basically below the lowest set of ribs. And you basically open the chest like a hood. In pediatrics, typically it's done on cardiac pulmonary bypass or ECMO. And what you end up with is 3 anastomoses, an airway anastomosis at the level of the main stem bronchi on each side, a pulmonary artery anastomosis, again at the level of the main pulmonary artery on each side, and then a cuff of left atrium brought back to the left atrium of the recipient. Sometimes we'll do an en bloc transplant through a median sternotomy, and in that situation, the surgeons will do a tracheal rather than a main stem bronchial anastomosis. And rarely in pediatrics, because of growth and infection issues, will we do a single lung transplant. If we do a heart lung transplant, and typically that's when there's LV failure and irreparable congenital cardiac abnormality or other issues with the heart, we'll do a tracheal anastomosis, an aortic anastomosis, and a right atrial anastomosis. The issues with heart-lung transplant is that the waiting times for these organ blocks are longer because of competition for isolated heart transplant, and the outcomes after heart-lung transplant typically track with outcomes after lung transplant. Initial treatments after therapy include triple drug immunosuppression, typically with a calcineurin inhibitor, cyclosporin, or more commonly now tacrolimus, a cell cycle inhibitor, typically mycophenolate mofetil, but sometimes azathioprine, steroids, either prednisolone or prednisone. And then some patients get induction either with a T-cell depleting agent or with an IL-2 receptor antagonist. In addition, patients get empiric antibiotics to cover the organisms which the patient is colonized with, and any organisms identified in the donor prior to transplant, and usually those antibiotics are continued at least through the first bronchoscopy, which is typically at 1 to 2 weeks after transplant. And then we also begin antifungal treatments, often with posaconazole for aspergillus. And then if the patient has either had CMV or the donor had CMV, we give prophylaxis with valganciclovir or valacyclovir in patients who've not seen CMV. Patients get prophylaxis with Ceftra for PJP, and oral candidiasis, we give nystatin. So you end up with a fairly robust regimen of medications, both in terms of immunosuppression and prophylactic antibiotics from the get-go right after transplant. So now we'll switch gears and talk about outcomes and complications after transplant. And I think if you take away anything from this talk, the first thing to take away is how the outcomes compare to other organ transplants. So this is what's called a Kaplan-Meier slide. Again, this is data from the International Society for Heart and Lung Transplant. What you have on the x-axis is the years after transplant, and at the y-axis is percent survival. And what I want you to see is 1 year, no matter which disease it is, 1 year post-transplant survival estimates are between 75 and 85%. You go out to 5 years, you're running around 50 to 60%, and it continues to drop off farther out, with most of the diagnoses after 10 years being under 50% survival. So the key take-home message here is that lung transplant, in contrast to other solid organ transplants, liver, heart, and kidney, the survival is not as good when you get out more than a few years. This isn't unique to pediatrics. This slide shows pediatrics in blue compared to adult in green. And you can see, if anything, pediatrics is a little bit better in terms of long-term survival than adults. But both groups have really poor long-term survival. We've done better over the last few years. This is the most current era in pediatrics, but most of that improvement is early, and the survival curves track in parallel once you get out beyond a year. The reasons that patients don't survive after transplant are shown on this slide. So what you have here is the percentage of deaths for different types of causes of death. The red curve here is chronic lung allograft dysfunction or bronchiolitis obliterans, which we'll talk about in a few minutes. And that's the predominant cause of death when you get out farther. Early graft issues and then infection are the commonest causes of death in the first year after transplant. So let's talk about what the complications are after transplant. And I like to consider 3 separate phases: the immediate phase, the early phase, and the late phase after transplant. And I like to talk about 4 complication categories. First, immunologic or rejection. Second, infectious. third, surgical or plumbing related, essentially, and fourth, other. So in terms of immediate complications, there are a few things that it's worth focusing on. I mentioned earlier the presence of donor-specific antibodies to donor HLA antigens can be a problem. And if they're present and you have a transplant with an organ with that HLA type, you can see something called hyperacute rejection, which means that there are circulating antibodies in the recipient that recognize tissue antigens in the donor organ, and particularly in the donor organ blood vessels, that cause clotting in the blood vessel right off the bat and really graft failure from the beginning. You can also see something called early graft dysfunction. And I should point out that with hyperacute rejection, it's rarely seen because we screen for those antibodies and avoid those tissue antigens when we select organs. Early graft dysfunction or reimplantation response or ischemia reperfusion injury are all the same name for basically what happens when organs come from someone who's suffered brain death, are taken out of the body, placed on ice, and deprived of blood and oxygen, transported to a transplant center over a period of time, and then are sitting there in that situation until they're reimplanted into a patient who's generally pretty sick in the middle of a big operation. So the longer time those organs are on ice, the more likely you are going to have what's called early graft dysfunction or reperfusion injury. And it manifests itself with increased infiltrates, inflammatory cells, and respiratory failure. Most of the time patients recover, but there is a long-term risk of poor graft function and late graft function in patients who have had severe early graft dysfunction. Infection can be a problem from the get-go, particularly if there are viral infections that come with the donor or are present in the recipient at the time of transplant. So we're screening donors for infection, and we're doing nasopharyngeal swabs and the recipients when they come in for transplant. And occasionally we've aborted a transplant when a patient came in with an unrecognized viral infection. And then surgical complications can come from any aspect of the surgical procedure. Bleeding can be common. Usually it's from an area where the old lungs had to be taken out and there's a blood vessel or blood vessels that haven't been adequately controlled. Any of the connections, the anastomoses, the main stem bronchus or the pulmonary vein or the pulmonary artery can break down and cause bleeding, and then other vascular complications can occur. So you can see kinking of the pulmonary veins is not uncommon, or torsion of the vessels. So any of the plumbing issues you have to be aware of. And usually we're doing a ventilation perfusion scan, at the time right after transplant, as well as an echo to make sure the blood vessels and the anastomoses all look okay. So we'll do the second poll at this point. You're caring for a 12-year-old patient with pulmonary hypertension who had a lung transplant 6 hours ago. Ischemic times were 7 hours on the right, 7:45 on the left. That's pretty long. Usually we're 4 to 5 hours max. Patient didn't have any antibodies to HLA antigens. And in the past 2 hours, he's developed pulmonary infiltrates, poor lung compliance, and moderate gas exchange abnormalities. So let's see here, we'll go. What is the most likely explanation for this patient with severe graft dysfunction? And we'll launch this poll and see what you think. It looks like most of you chose D, primary graft dysfunction. Pulmonary vein obstruction would also be a possibility, although usually that's unilateral, and acute rejection this early is less likely. Sorry. So the right answer was primary graft dysfunction. So we'll now move on to the early phase post-transplant. And this is after the first week up until 3 months or so. Infection because you've immunosuppressed the patient, and in the first few months you're at the highest levels of immunosuppression. That typically is one of the most common things we run into in our pediatric lung transplant program. And it can be the entire gamut. It can be community-acquired bacterial infections. It can be organisms present in the recipient or the donor prior to transplant. MRSA and Pseudomonas are common, particularly in our CF population. Fungal organisms, most worrisome is Aspergillus, and that's why we're using azole prophylaxis, and Candida as well. Viruses, including cytomegalovirus or CMV, and that's why we're using ganciclovir or valganciclovir prophylaxis. Adenovirus and RSV can be particularly problematic in pediatric lung transplant recipients. And then opportunistic infections like PJP can be a problem. And so this is what CMV looks like under the microscope. This is a lung biopsy. You can see this fairly prominent nucleolus and foamy cytoplasm. And this is what CMV pneumonitis looks like. And that's why we're giving ganciclovir. The second most common complication is acute rejection. And the symptoms and findings look a lot like pneumonia. Patients can present with cough and respiratory difficulty. They have fever and inspiratory crackles. Their white count is elevated. Their lung function is decreased. They often have perihilar infiltrates and sometimes can have pleural effusions. This is what acute rejection looks like under the microscope. This is a transbronchial biopsy. You see this blood vessel here that's surrounded by blue cells. This is called perivascular cuffing, and that's the hallmark of acute rejection. If you go out to grade A3, the perivascular cuffing extends into the interstitial space, and acute rejection is graded A0 to A4 based on an ISHLT scheme, and A4 is the most severe form of acute rejection. We treat acute rejection with pulse steroids initially, with typically methylprednisolone at 10 mg per kilo for 3 doses daily. Often we're reassessing with a biopsy 2 weeks after this treatment. And if the acute rejection persists, particularly if the acute rejection is worse, we'll give either more steroids or antithymocyte globulin. The second type of rejection that you can see in the first few months after transplant is called humoral rejection or antibody-mediated rejection. Similarly, it can look like pneumonia. It can also be asymptomatic. The key here is the presence of antibodies to the donor that develop after transplant. So often patients will be free of antibodies prior to transplant, but then over the course of time will develop donor-specific HLA antibodies. And if those antibodies become a problem, you'll often see capillary loop staining with complement. So we look for C4D. So this is a picture of antibody-mediated rejection. You can see these sort of neutrophils along the line of where a capillary would be in the interstitial space. The presence of capillaritis is a good indicator of the presence of antibody-mediated rejection. And then if you look with C4D staining and you see the C4D staining again along the capillary walls, particularly here, for example, that's also strongly supportive of the presence of antibody-mediated rejection. Antibody-mediated rejection or humoral rejection is treated a little bit more challenging treatment than with acute vascular rejection. And there's many options and they're controversial. We'll usually use pulse steroids. We're often treating with plasma exchange to remove the circulating antibodies. We'd use proteasome inhibitors like carfilzomib to try and get rid of the plasma cells that are producing the antibodies. We usually will give, in serious cases, severe cases, B-cell depletion with rituximab. Some people use complement inhibition with eculizumab, and some patients, particularly those who've been refractory to the other therapies, get antithymocyte globulin to try and remove both the T and the B cells from the circulating population, but it's antibody-mediated rejection can sometimes be difficult to treat. In terms of surgical complications, the airway anastomoses can have narrowing or malacia, narrowing from granulation tissue at the surgical site. We see it more commonly in infants, and it's typically thought to be related to ischemic injury to the main stem bronchi. Patients can present with respiratory difficulties and obstruction on spirometry. Generally, this is treated with serial dilation using rigid bronchoscopy and a balloon catheter. Rarely we place an endobronchial stent, but that comes with many, many complications in turn, including obstruction of the stent, development of granulation tissue, and then as the patient grows, that stent can become too small. So generally, we're trying to avoid stents and using balloon catheters. The second surgical complication is a breakdown of the anastomosis of the airway. This can also be asymptomatic, but it can present with mediastinum on chest x-ray or chest CT, and can also present with catastrophic failure. Generally, in the patients who just show up with a little bit of air leak, we're trying to use a conservative approach. The phrenic nerves are often in the path of the surgical procedure, and so patients can present with unilateral or bilateral diaphragm for paresis. Typically, we're trying again to be conservative about treating this and wait to make sure that the diaphragms aren't going to come back after several months after transplant. But patients who have recurrent infections or atelectasis sometimes get the diaphragm plicated. And finally, the recurrent laryngeal nerve on the left side goes through the area of the operation and can sometimes be injured, leaving left-sided vocal cord paresis. Other complications we see in the early post-transplant period: hypertension is a common side effect of calcineurin inhibitors. Seizures can be seen, again, thought to be related to calcineurin inhibitors. This is something called posterior reversible encephalopathy syndrome, or PRES. Typically, it's reversible and doesn't require treatment, but occasionally it can be severe. Renal failure can be seen in the early post-trans period, typically in patients who have pre-existing renal dysfunction. Gastrointestinal issues can be a significant problem, often seen in the CF population. Delayed gastric emptying can make reflux more likely, and aspiration can be a major issue in these populations. So we're paying attention to GI symptoms, often looking for evidence of reflux, considering fundoplication to make sure that we're not having significant airway soiling from aspiration. And then in the CF population, occasionally we'll see distal intestinal obstruction syndrome, and we're generally trying to prophylax with that by cleaning patients out before the treatment, before the transplant, and then being very thoughtful about monitoring their stool output after transplant. And then finally, you can see arrhythmias typically at the suture line in the left atrium, and they can present with SVT. Those generally are self-limited, but occasionally require any arrhythmic therapy as well. So the second post-transplant case, you're evaluating an 8-year-old with cystic fibrosis, 2 months after transplant with fever and cough. Patient is tachypnic with a little bit decreased SATs. Won't do the PFTs at home, but in the lab they're down a bit. Patient's in mild distress with crackles at their lung bases. White count is up. The chest x-ray shows perihilar infiltrates and a small right pleural effusion. You do a bronchoscopy to look for evidence of infection or rejection, and you see that the anastomoses are intact and patent, so there's no airway obstruction. There's really not much in the way of mucus, and the gram stain on your bronchoalveolar lavage showed moderate polymorphonuclear lymphocytes, but no airway organism. So the question is, what's the most likely diagnosis for this patient? And is it community-acquired pneumonia, acute cellular rejection, viral pneumonia, or bacteremia? So it looks like most of you chose B, acute cellular rejection. Some folks thought C, viral pneumonia. Some thought A, community-acquired pneumonia. And the correct answer is acute cellular rejection. Viral pneumonia is a good thought with the perihilar infiltrates. I didn't mention that the NP swab was negative, which or the viral PCR was negative, which would have made that easier. Community-acquired pneumonia, you would have typically expected to see something on your gram stain. So now let's talk about late complications after transplant. You can still see infection, you can still see acute or humoral rejection, although the frequency of the latter decreases after 3 to 6 months after transplant. Developmental delay often surfaces, particularly in younger patients who really had a rough time prior to transplant. Renal failure and diabetes are also things that we see in the patient population. This is data from the ISHLT again, and you can see that severe renal dysfunction comes in up to 7.8% of patients, including 1% of patients in the pediatric population that end up getting renal transplants because of calcineurin inhibitor toxicity after transplant. Diabetes is also a fairly common finding, particularly in patients with cystic fibrosis, and more commonly now that we're using tacrolimus. So patients who don't have CFRD prior to transplant often end up with CFRD after transplant. Malignancy is also a potential problem after transplant. Typically, it's something called post-transplant lymphoproliferative disease, or PTLD, although other malignancies can be seen. And again, data from ISHLT suggests that malignancies are somewhere between 5 and 10% after transplant, most of them lymphomas. So PTLD is usually a B-cell non-Hodgkin's type lymphoma that affects 5 to 15% of patients. It's associated with Epstein-Barr viral infection, and so that's why we're checking EBV infection prior to transplant. Risk factors include cystic fibrosis and acute rejection episodes. In our center, elevated EBV PCR levels are sensitive but not specific, so we are monitoring patients with EBV PCRs after transplant. And initial treatments typically are following a children's oncology group protocol with rituximab, with low-dose cyclophosphamide and prednisone, but some patients require chemotherapy. You can also see skin cancers in this population because of their increased risk from sun exposure. And this is what post-transplant lymphoproliferative disease looks like. You can see these sort of nice, well-circumscribed nodular infiltrates here and here and here, with a more consolidation here. This patient after treatment actually cleared all of that. So patients respond generally fairly well with Rituxan and cyclophosphamide. So the last late complication that I want to focus on, again, is something that it's probably important for you to remember going forward. It's the second thing you take away from this conversation. It's chronic lung allograft dysfunction, or CLAD, and it comes in two forms: bronchiolitis obliterans, or obliterative bronchiolitis, and restrictive allograft syndrome, or RAS. And the reason that this is such an issue is that by 5 years after transplant, at least 50% of patients have some form of chronic lung allograft dysfunction. In this IHLT slide, they focused on bronchiolitis obliterans syndrome, but it's the same numbers for everybody. So chronic lung allograft dysfunction has what's called an obstructive form, or bronchiolitis obliterans, and you can diagnose it either with histology or with pulmonary function tests, and primarily a restrictive form that's diagnosed with pulmonary function testing predominantly. And if you follow pulmonary function tests after transplant, this is what it looks like. This is a patient who got transplanted here and had normal lung function for the first 2 years after transplant, then had a relatively rapid drop-off in FEV1 and FEF 2575, followed by a drop-off in FVC. And so they started with an obstructive picture and then developed a restrictive picture as well. And unfortunately, this patient didn't survive at that point. This is what bronchiolitis obliterans looked like under the microscope. You can see this is an airway. You can see the smooth muscle here. There is some loose proliferative tissue here. This can start pushing into the airway in a lower power view here. And as this progresses, you can see complete obliteration of the airway. You see the smooth muscle here and fibrous tissue here. And as you can imagine, gas exchange in this airway is pretty poor. Outcomes after the diagnosis of CLAD are poor. Again, this is Kaplan-Meier curve. This is time after transplanted patients who do not have CLAD, who have bronchiolitis obliterans syndrome or restrictive allograft syndrome. And this is after diagnosis of CLAD with bronchiolitis obliterans syndrome and RAS. And the take-home message here is survival is poor for both forms of CLAD, but for patients with RAS or restrictive allograft syndrome, the outcomes are much worse than with BOS alone. And if you look at retransplant outcomes, it's even worse for RAS as well. So the risk factors for CLAD include acute rejection episodes, presence of lymphocytic bronchitis or bronchiolitis on biopsy, gastroesophageal reflux, which is one reason we're paying attention to it prior to transplant, development of donor-specific antibodies, development of autoantibodies, particularly to K-alpha-1 tubulin and collagen-5, persistent or recurrent bacterial infections and respiratory viral infections, and as I mentioned earlier, primary graft dysfunction. Treatment for CLAD is difficult. We typically start by increasing immunosuppression if there's evidence of ongoing inflammation, usually with T-cell directed cytolytic therapy. There's some evidence that azithromycin as an anti-inflammatory can treat a subset of patients with CLAD. We make sure we address any evidence of reflux. And then the last-ditch therapies are photopheresis, which is basically a form of pheresis where we take sorolin, inject it into the patient, and use that with ultraviolet light to try and reduce inflammation. And then last-ditch is retransplantation. But as I mentioned, retransplantation, particularly in restrictive allograft syndrome, has poorer outcomes. So there's really no effective therapy for CLAD, unfortunately, in our patient population, and that's one of the reasons that lung transplant has a poor overall outcome than other types of transplant. So this is the last poll case. You're seeing a 16-month-old who's 9 months post-transplant who presents with persistent fever and poor PO intake, treated 3 times in the last few months with otitis or bronchitis, normal saturations, lungs are clear, slightly distended abdomen, really nothing new in terms of the white count. EBV PCR has been elevated, but it's been there for a while. He did a bronchoscopy, a little bit of mucus, a little bit of alpha strep, a little bit of lymphocytic bronchitis. And the chest CT scan shows focal nodules in the left base of the lung and the kidney with some thickening in the mesenteric portion of the intestine. So the question is, what's the most likely diagnosis for this transplant recipient with persistent fevers? And is it acute rejection, PTLD, bronchiolitis obliterans, or fungal pneumonia? And most of you chose B, post-transplant proliferative disorder, which is the correct answer. So I just want to spend a few minutes talking about challenges. I think I mentioned that the numbers are relatively flat and it's distributed over a small number, but a real number of transplant centers. So experience in pediatric lung transplant is limited. CF and pulmonary hypertension both have had improved survival over the course of the last 20 years. So that group of patients is decreasing overall in the overall patients coming to transplant, although it's not as clearly seen in the ISHLT data. And then if you look at the adult lung transplant numbers, it vastly outnumbers pediatric lung transplants. And so these are just climbing to almost 4,000 lung transplants in adults compared to the 100 to 130 in pediatrics. And so competition is significant for organs. So the challenges facing pediatric lung transplant centers is a more even distribution of pediatric transplants across centers. The population of candidates is changing. There's increasing competition, increasing candidate acuity, therefore, and that's placing our outcomes for patients at risk. And we're being faced with a need to bridge to transplant more consistently, and talking about different strategies for ECMO and other mechanisms of support. ECMO, in our experience, this is early on in our data, these are patients who were transplanted on ECMO that had really poor outcomes. And so we've evolved in our approach to bridging to transplant, including now using VV ECMO as opposed to VA ECMO, as well as some strategies for pulmonary hypertension using a pumpless oxygenator in parallel to the pulmonary venous circuit to bridge patients to transplant with refractory pulmonary vascular disease. So these are just some things that are out there in terms of challenges and opportunities in pediatric lung transplant going forward. So now I've left a few minutes for a virtual table exercise. Hopefully everybody has received the document that Liz shared earlier with the questions that we have. And so we're going to break people up into virtual breakout rooms with 8 to 10 people in it. When you get into the rooms, feel free to turn your video on and make sure you unmute yourselves. Identify a spokesperson for the group, because I'm going to ask some questions when we come back together. If no one volunteers, whoever's first in alphabetic order is the guinea pig. And then I want you to discuss and develop answers to the assigned case from the materials that were provided, and be prepared to provide answers and rationales when we come back together. So Liz, I think we're ready to go with the breakouts. Okay. So are you guys seeing my slides? And people are going to have to unmute again, especially the people who are going to be the spokespeople. But maybe the people in breakout room 1 can tell us what you thought your differential diagnosis was for the first case.
Sure. I think we had discussed that we had thought about alveolar capillary dysplasia with displaced pulmonary veins, surfactant B deficiency, and as being the more likely.
So ACD-MPV is a good thought. Pulmonary vein stenosis was the other thing that could present this way. I think that having the suprasystemic RV pressure is a key, although the X-ray findings aren't quite as consistent with pulmonary vein stenosis. SPB would be sort of third on my list. So what diagnostic tests were you going to do?
So given how unstable the patient is, we thought on doing some genetic testing initially. Imaging doesn't seem possible to happen. So we thought starting with genetic testing. Yeah,
I think that's a good idea, especially for FOXF1, which is the genetics associated with ACD-MPV. So yeah, that's a good thought. And lung biopsy is something that's going to be on this kid's table at some point, but right, doing the genetics first makes sense. So maybe group 4, you could tell us what you thought you were going to say to the transplant or the parents if transplant's on the table. You may need to unmute yourself.
I think from all the review, like looking at all the overall prognosis, sounds like the 5-year survival rate is around 50%. So I would think the long-term prognosis to be poor.
Right. So what I usually tell parents of infants is that if you're expecting to have your child live into adulthood, the odds are against you. But I apologize. My slides are messing up here. Bear with me for 1 second. And so generally, I'm telling patients at that age group that they have to have a realistic understanding of what's likely going to be the outcome, and be willing to accept the reality that the 5-year survivals are 50%. Retransplant is a reality for many children. And so they have to be willing to go into that with the understanding that that's the long-term prognosis. So let's move on to case 2. And room 2, can you tell me what you said in terms of offering transplant evaluation? Again, you may want to unmute.
I can go. So we discussed how, obviously, as you had mentioned in one of your slides, referring earlier is usually better, but it seems like in this case, there are a lot of possible interventions to be done prior to really considering transplant. If she had had an FEV1 of 50% pretty recently, it'd certainly be hopeful that we could get her back up and closer to that, and thus, the concern that she would require transplant would be a lot lower. It seems like well, I don't want to answer the second question, so I can stop there.
Well, you can move on. I think there's lots of relative contraindications to this patient, but nothing absolute. And so you just need to make sure you've got your ducks in a row before you go down that path. The adherence issue is a significant one. So that's why I wanted to ask how you would approach that. What did you guys think about approaching adherence? And there's no room 5, so you guys are it for this whole case.
We talked about wanting to know more about the social history and whether or not this foster placement is long-term, and getting a little more information on that, because adherence and stability of home may have a lot to do, maybe intertwined. And so that we talked more about that.
Right. And she'd just been adopted by the foster parents. And so maybe that didn't come clear through the case, but in our center, we require the patient to be in permanent custody before we'll move on to transplant. What I was getting at in this question was also sort of how do you navigate managing and adherence? Do you set up expectations? Do you put a contract in place with the CF center and get the patient to follow through on that contract before you bring them to transplant? Those were the things that I was trying to telegraph here. I guess I didn't do a great job of that. And then the last question, sort of what considerations would affect timing? You mentioned trying to get the FEV1 back up to 50%. I think when I was wandering through, I heard you mention one thing about different therapeutic trials that you might want to come back to. Did you have any specific things in mind?
Yeah, so we had talked about, potentially reassessing her history of atypical mycobacteria, of potentially doing like bronch BAL to get more cultures, that potentially if she was admitted for the 2 weeks and was getting IV antibiotics, maybe she wasn't getting covered appropriately, maybe she needs an adjustment in that. And then also just, it doesn't mention anything about CFTR modulators. I'm not sure, when this case was written, but that would be another consideration.
No, that was actually those are all good ideas, but yeah, an 11-year-old who may or may not be able to get access to CFTR. The other thing that's interesting is access to transplant changes in the current system once you hit 12 years of age. And so CFTR availability or modulator availability and responsiveness, and then also timing in terms of allocation in the United States would be factors that you would play into in this case. So then we'll move on to case 3. What do you folks think the most likely diagnosis was in this patient from room 3?
I'm honestly forgetting if we were room 3 or 6, but we were talking about antibody-mediated rejection, with the last line talking about the new finding of new donor-specific antibodies.
Mm-hmm. Yeah, so that certainly antibody-mediated rejection could be playing a role. In this situation, I'm concerned about restrictive allograft syndrome as well.
Okay. With the FEV1.
Yeah.
Okay.
What treatments would you consider then in this patient?
Well, we talked about in the setting of the antibodies, doing high-dose steroids, plasmapheresis.
Yeah.
Two things talked about.
And you're right, even though you're worried about RAS, you're probably going to treat the antibody-mediated rejection component. You may move on to photopheresis in this setting, and then retransplant, as I mentioned, would be a consideration. So if you're going to talk about retransplant, how are you going to counsel the patient?
I think we discussed that for RAS specifically earlier and talked that the outcomes post retransplant in that particular scenario are worse.
Right. Good. All right. Good job, everybody. So that's really all I wanted to get through. I apologize for keeping you over a little bit. I won't go through these in details, but I'd be glad to answer any questions if people have them. Jim, I'm running over, so I don't think you're going to want to ask any questions.
I think you did a great job, Stuart. Thank you so much. Super appreciated. And I like the new format. So again, thank you very much.
Terrific. Well, thanks everybody for hanging around for the end. Take care.
Bye-bye.